Hello Health on LAE is presented by the Ochsner Health System, a nonprofit academic multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Ochsner Health System includes 8 hospitals and 38 health centers located throughout southeast Louisiana. Ochsner, healthcare with peace of mind.
We call it our More Money to Spoil Our Grandkids plan. With a Humana Medicare Advantage health plan, we get tips on how to make our money go further. We even get a health finance and benefits statement called Smart Summary that helps us find even more ways to save. And we like more.
More of what you want, because you deserve more.
Good evening, I'm Tom Bagwell, and welcome to Hello Health, a partnership with WLAE, the Ochsner Health System, and Humana to bring Ochsner's Hello Health weekly education and information series to television. Tonight we're going to be talking about heart disease and how certain cancer-related treatment therapies like radiation and chemotherapy might put you at risk. 2 guests on tonight's program, Dr. John Cole, who's been here before, and Dr. Jahangir. In the second half of our program, we'll be taking your questions live by phone at 504-866-3200. That's 866-3200. And by email. You can email your questions to us, as a couple of you have already done so already, at hhquestions@wlae.com. We'll ask you to hold off on the phone calls for just a little while. Now let's meet our 2 guests. Dr. John Cole earned his medical degree from the LSU School of Medicine here in New Orleans. He completed both his internship and residency at Ochsner before completing fellowships in hematology and oncology at the Columbia Presbyterian Medical Center in New York. Dr. Cole is board certified in internal medicine, hematology, and medical oncology, while his special medical interests are in breast cancer, general hematology, and oncology. Dr. Cole has been on staff with Ochsner since 1989, and we are delighted to welcome him back to our program. Well, Dr. Cole is joined tonight by his colleague, Dr. Jahangir, an award-winning cardiologist with an extensive training and experience in research, investigation, and clinical patients. Dr. Jahangir received his medical degree from the University of Tennessee. He completed his residency in internal medicine in Boston University's Medical Center before completing his fellowship in cardiovascular medicine at Vanderbilt University. Went home for that. He's from Nashville. Dr. Jahangir is board certified in internal medicine and cardiovascular disease. He currently serves as the director of the research for the section of consultative cardiology and is also co-director of the new cardiac oncology clinic at the Ochsner Medical Center. Dr. Jahangir has been with Ochsner since 2013, and we're very pleased to welcome both of our doctors to Hello Health. Good to have you with us. Thanks. And Dr. Cole, good to have you back. So Dr. Jahangir, let's talk with you first about what was it or who was it that first got you interested in medicine?
Yeah, so I grew up around medicine because my father is a radiologist, and really what solidified, so I always knew I wanted to do medicine, but what solidified going into cardiology is that my grandfather had a heart attack when I was young and subsequently developed heart failure. So I saw how important it was and the impact that had on our family and how important it is to prevent those kinds of things, and that led me to a career in cardiology.
Very good. And Dr. Cole, for the people who didn't see you the first time you were with us, do you remember what it was you told me back when you were here for the first time? And what was it or who was it that got you first interested in medicine?
Well, I think it just fit into my natural affinity for science, and it struck me as being a great way to help people, and I think that's really the thing that attracted me to medicine, and specifically to oncology and cancer care.
All right, before the not to embarrass you or your daughter, you told me you have a daughter at Newman, a junior, and has an interest in perhaps pursuing a career in medicine.
Hopefully
right?
so. That would be great.
All right, we'll see how that goes. Well, Dr. Jahangir, we mentioned in your introduction that you're heading up a new unit at Ochsner and working with your colleagues here like Dr. Cole. Tell us about it and how did it all come about?
Yeah, so when I came to Ochsner, I noticed that we were seeing some patients from the oncology service for various reasons, and Dr. Cole, myself, Dr. Poland, and a few other colleagues of Dr. Cole sat down and started to talk together to figure out how we could best manage these individuals. So we really were trying to find a way to provide the best care for patients undergoing chemotherapy and also be there as a support system for people who develop problems while they were going through therapy, and that way they would already have a relationship with us. So we sat down and had a conversation, and it led to the formation of this clinic, which is one of only a few in the country. There's only a few programs doing this right now, and the only one in Louisiana at this time.
You've got a big smile on your face when he's talking about all this. I mean, you're always smiling. I remember that from the last time you were with us. But in particular, a big smile, probably of pride. And how's it going? You're probably pretty pleased with what you've seen, right?
Well, I've been thrilled with the clinic, and I think it's the great part about it has been it really provides our patients with something that we couldn't give them before, which is a way to make sure that we optimize their heart care all the way through their treatments from beginning to end. And also it's allowed us to create a system where patients will get the appropriate follow-up that they need. And also it's providing us with a great platform to do some research in an area where there is not as much known as we'd like to.
And we'll talk about some of those research trials in just a few moments. And that is our topic tonight, the link between cancer treatment and heart disease. So Dr. Cole, let's start with you. What are some of the risks people face with cancer today?
So the biggest challenge we have is really designing therapies that are going to optimize our results and hopefully cure patients, and at the same time dealing with the potential negative effects of chemotherapy and other treatments that we give, which often can have negative effects on normal tissues. And obviously the heart is one of those that we're concerned about and talking about tonight, but that can be true for many other tissues as well. So trying to minimize the negative effects that we create while maximizing the patients that we cure is really, I think, our biggest challenge.
And we're going to show people here a list of all the cancers that we're facing today and patients are facing and you're helping battle. Talk to us about the most common types of cancer for men and for women.
So for men, prostate cancer is the most common. In second place is lung cancer, unfortunately, smoking-related cancer. And then other cancers include bladder cancer, melanomas, kidney cancers. Those are other frequently seen cancers in men. And for women, breast cancer is the leading cause of cancer by far. Lung cancer also an important cause of cancer, and especially cancer-related deaths in women. And then uterine cancer, thyroid cancer, melanoma, and lymphomas for both men and women are important cancers.
That's the bad news. The good news is the cancer survivor rate is getting higher. How much improvement are we seeing here over the last couple of decades? And do you think that number is going to continue to get better?
Well, first I can say I'm sure the numbers are going to get better. I'm really absolutely confident of that. We've seen about a 22% decrease in cancer mortality over the last couple of decades, and I think that's partially related to earlier detection and finding patients when we're more likely to be able to cure them. But it's also related to better treatments for patients who do have advanced cancer problems. So the result of that is that we expect to see more and more survivors of cancer over the years, and although right now there are about, I think, 14.5 million survivors of cancer, up from about 3 million in the mid-70s, it's expected by 2020 we'll have about 18 million cancer survivors, and that number is going to continue to go up.
And are there any particular initiatives you've seen that you think have made a difference with this early screening? Because the fact is you've had screening capabilities for a long time. It's people having to take advantage of them, correct?
Right. So we have, obviously, mammography for breast cancer is a long accepted screening practice, a bit controversial in terms of the specifics of that these days, but I think still widely accepted as being an appropriate thing to do. PSA screening for prostate cancer also has the potential to have earlier detection and save lives, although there's been some recent controversy there as well. Screening for colon and rectal cancer with colonoscopy.
We keep hearing that's a preventable, one of the most preventable cancers there is.
Absolutely.
With early screening.
And then recently we've found that CT screening for patients at high risk for lung cancer, those people who are heavy smokers for a long time, can also find cancers earlier and improve survivals. So those are some of the things that we can do right now.
All right. Well, Dr. Jahangir, let's turn to you. Heart disease, the link and association between heart disease and cancer treatment, and that's really your area of specialty here. What is the link and what progress are we making there?
Well, it's a twofold kind of answer. The first thing is we know that heart disease is the #1 killer amongst all Americans and actually in the world. As we've gotten better at fighting off infectious diseases and other things that traditionally killed people, people are living longer, and heart disease ends up being, if you're lucky enough to live long enough, what takes you out, unfortunately. So everyone needs to be worried about heart disease, and once you hit 60 years old, actually about 70% of people will have heart disease. The link between cancer and the heart comes from not only survivors living longer, which is great and what we want, and thus, therefore being susceptible to other things, but also that we know some of the medications we use to treat cancer, such as anthracycline chemotherapy or HER2 receptor inhibitors, along with certain radiation therapies to certain parts of the body, can affect the heart. So really it's twofold in the sense of, one, if you're a cancer survivor, that's great, that's what we want, and you're going to have the same problems the rest of us are going to have. Two, we know that some of the medicines that we use can affect the heart going forward.
Is there one in particular of these treatments that causes the most risk or danger to the heart?
The classic one we think about is anthracyclines, and one of the reasons it's the classic one is it's one of the ones we've used for the longest. So we have a lot of data on it from the 1970s going forward and have gotten pretty good at preventing the risk from it, but that's probably the biggest one that we think about.
Dr. Cole, anthracyclines are used to treat primarily what types of cancers?
So one of the most widely used treatments for breast cancer, which as we mentioned earlier is a very, very common cancer in women. It's also used to treat gastric cancers, used to treat both non-Hodgkin's lymphomas and Hodgkin's lymphomas, bladder cancer. So a number of different cancers can be benefited by anthracycline therapy. So it's an extremely useful drug.
And what is it and how does it work and how does it battle the cancer?
So anthracyclines inhibit a certain enzyme that's important for DNA replication called topoisomerase. And so that inhibition of that enzyme can impair DNA repair, which is a very bad thing for cancer cells because of the way they have to grow. But all cells use that enzyme as well, and so it can create problems for normal cells as well.
And how does this impact in a negative way the heart?
So the inhibition of this enzyme can cause direct damage to the heart muscle itself.
Okay. Dr. Jahangir, cardiomyopathy, remind us, give us the definition again, and how does this anthracyclines might affect cardiomyopathy? And you said this is something that's actually touched your family, right?
Very closely, yes, sir. So cardiomyopathy is just when the heart doesn't squeeze normally. So it's a term we use for a decrease in ejection fraction, which is basically the squeeze. You know, the heart is basically a pump, and it just sits there and squeezes back and forth. And if we see a drop in that pump's function, where instead of pumping 55% of the blood forward like it normally would, say it pumps out 45%, then we start being concerned that there's been damage to the heart. That's different than heart failure, which is when people actually have a cardiomyopathy and develop symptoms.
And are there other things that cause cardiomyopathy other than anthracyclines or any other cancer treatment options?
So the #1 most prevalent cause is blockages in the arteries of the heart. So cancer-related or chemotherapy-induced cardiomyopathy is a very, very small portion of it, but what we're hoping to do with the clinic is decrease that number even further.
Once there is this damage, can it be reversed?
So it's a tricky question. It depends on if it's just isolated to the cancer treatment or not. Typically, what's happened is that the oncologists have gotten so good at paying attention and screening people and decreasing the risk of it from the anthracycline therapy that we try to catch it before it happens or catch it before it becomes too significant. So we've really gotten better at initiating therapies to halt the progress of disease and go on with another type of treatment.
Okay. Dr. Cole, you talked about HER2 receptor inhibitors. How is this used to treat cancer? How does it work, and what types of cancers would you use these?
So most cells have receptors on the external portion of their surface, which allows them to receive signals that tells them to do certain things. Those are normal functions in cells.
Grow, stop grow, right.
Correct. Survive certain conditions, etc. And so when these receptors become overactive, or in the case of breast cancer, overproduced, this signal gets turned on in a fashion that's not normal and gets overactivated. And that overactivation for breast cancer patients, for example, means that those cells grow more rapidly and they are more resistant to some other types of approaches we might want to use. So if we inhibit that receptor with an antibody that blocks it, we can then prevent the overactivation of the cell. In fact, we can make those cells more sensitive to death by treating with chemotherapy, and also we can at the same time make the body's immune system more likely to attack the cancerous cells. So that can be an extremely important treatment, in fact a critically important treatment for patients who overexpress the HER2 protein, and has basically taken a group of patients that otherwise had a very guarded outlook and has created, has basically erased the negative aspect of that finding. We also use anti-HER2 treatments for patients with gastric cancer as well, and some lower esophageal cancers. So that particular approach of receptor inhibition for the HER2 protein has grown in its utility.
And how might this affect the heart and the heart muscle?
So the effect of the HER2 agents on the heart is actually reversible, and those same receptors that we see on cancer cells are actually existent on the heart too. So while the therapy is great in blocking the receptors on the cancer, they also have the same effect on the heart, and therefore it can cause the heart muscle to decrease in function temporarily. Through kind of the same mechanisms, it's just we found that the cancer has it and also the heart has those receptors.
Is there a way to predict, because this may not be the case in all patients who are negatively impacted with the heart, are there ways to predict who might be more susceptible to this heart damage?
So there are a few ways to predict. One, when people come see us in clinic, one of the first things we do is take a history. And that way we get an idea as to their risk factors. Do they have a family history? Do they smoke? Other things that could lead to heart disease. Then we also have the ability to do certain tests, such as doing an echocardiogram, which is an ultrasound of the heart, that will allow us to see what the heart pump function is like.
And we can show people what that looks like.
And if you can see on the left there, that's a normally functioning heart. And we've actually gotten even better from just having an echocardiogram, and now are able to measure something called LV strain, which is gives us the ability to identify certain specific parts of the heart and how they're moving. Beyond that, there's a lot of things going on. For one, we're participating in a trial right now using MRI to see if we can predict earlier. Also, we use certain blood tests that sometimes we check if we think it's appropriate in certain patients to basically identify if they're at risk. So we have a lot of tools in our hands that we can use, and it just depends on the person and what their risk is beforehand, and then we decide.
All right. Go ahead, Doctor.
And I think that it begins with identifying patients that are going to be at risk, and so that starts really in the oncologist's office, where we say, Mr. Jones or Mrs. Smith, you're going to be receiving a therapy that could potentially have a negative impact upon your heart function, and that's when we set the process in place where we begin the screening, get the consultation with the cardio-oncology group, so that we can optimize things from the very beginning and not try to play catch up later on down the line.
We saw the echocardiogram there. Either of you seen the 4D look at the baby?
Yeah.
Is that available for heart? I'm a little off topic here, but certainly relevant.
So we do have the ability to do 3D echocardiograms. We're not routinely using them in our clinic for validating if someone's at risk, but that's an area where we could do more research and see, would the 3D echocardiogram actually be more effective in predicting this than the 2D echocardiogram?
But they are available in some places?
They are available at Ochsner, yeah.
Is it the type of thing you'd like to have one? I'm lobbying here for you. I'm helping you lobby.
The heart's not as cute as a baby.
Okay. So you talked about doing things on the front end. Are there things we can do to prevent or minimize risk once you know there are risk factors in place?
So there have been a number of trials that have been done. As we mentioned, we're participating in some now, and hopefully as we see more people, we can actually contribute to that research. But there are certain things that if we identify someone that's at an earlier risk, we may put them on certain types of medications, such as ACE inhibitors or beta blockers. They're typically used in treatment of the individuals with cardiomyopathy. So what we've learned to do is that in some studies they've demonstrated a benefit by putting people on these medications, that we may be able to avoid the damage to the heart.
Are these ACE inhibitors or beta blockers good for everybody? Do they make sense for all patients with this risk?
They don't make sense for all patients because, one, we don't like to give people medicines that are not required. Secondarily, there can be side effects from them. So we really like to tailor it to the individual. So that's why it becomes important to have a history and also obtain things like the echocardiogram and blood work to make sure that we're giving it to the right person. We never want to unnecessarily treat individuals and put more things on their plate when they're going through a hard time.
All right, let's delve a little deeper into the screening protocol for evaluating these cardiac side effects.
So again, as I mentioned earlier, we start by identifying patients at risk, and by doing that, we look at the type of therapy that we're envisioning patients to have. And in addition, I think we're getting smarter. Our cardiology colleagues are making us smarter about the other risk factors that patients might have in place, things like diabetes, pre-existent hypertension, hyperlipidemia. And I think that's one of the things that we found is there are a lot of patients whose just general cardiac care needs a tune-up, and so they kind of can get that at the same time that we're evaluating to make sure that we can give them their treatment in a safe fashion. And then once they get to the cardio-oncology clinic, then they get really a whole program of what needs to be done in terms of initial really preventative therapies, but also a game plan for what needs to be done in follow-up.
Yeah, and what is that follow-up process once a patient's been treated?
So, we start with the echocardiogram like we've discussed, and I think we have a slide of someone having an echocardiogram to show, but the echocardiogram is just the ultrasound of the heart, and after that baseline one, we'll undergo treatment, and depending on anthracycline versus HER2, if it's anthracycline therapy, typically what we do is we do it at the end of treatment. And then there have been some studies that recommend doing it 6 months, a year, and even up to 5 years after treatment. So it's important to stay plugged in with us so we can decide exactly how frequently someone needs it. With the HER2 treatment, we're a little bit more aggressive. We do it every 3 months while they're on treatment after the baseline, and then we'll do it up to 2 years afterwards. And that's just to make sure that there's no residual effects or that the heart is normalized if there was any problems.
Very good. We want to invite you to call us with your questions about heart disease and the link between heart disease and cancer treatment therapies. You can call us right now. Our phone number is 504-866-3200. That's 504-866-3200. Or you can send us an email, and a couple of you have already done that, maybe even more, at hhquestions@wlae.com. And again, you can call with your questions now, or send us your emails, or call to share your stories about your cancer treatment and perhaps heart disease as it relates to that. Dr. Cole, let's talk about radiation now, which we haven't yet. Which forms of cancer is radiation used most commonly to treat?
So radiation really is something that can be used for just about any type of cancer. It's a standard component of treatment for our breast cancer patients in many cases, especially those who undergo more limited surgery, lumpectomies, for example. It's very widely used in patients with lung cancer to help treat the primary tumor. And as we mentioned earlier, that's a very important cancer for both men and women.
And we've got an image there. Exactly what's happening. Remind us what's happening in radiation.
So with radiation therapy, there is a radiation source. In this case, it is an external beam, and the beam is directed in a very measured and calibrated fashion to the area of the body that is to be irradiated. And so one of the big advances in radiation has been our ability to focus that beam ever more carefully and to avoid irradiating structures like the heart that we know could suffer long-term consequences. Nonetheless, there is a consequence to radiating normal tissues primarily mediated by damage to the small blood vessels. So one of the things that often happens to irradiated normal tissues is development of scarring or fibrosis.
But on the positive side, radiation is helpful in which ways?
Well, radiation is a very effective killer of cancer cells, and so in combination with chemotherapy or sometimes given sequentially after chemotherapy, it's often a critically important thing for achieving control of where the original cancer started out.
Dr. Cole touched on it, but Dr. Jahangir, talk about the risks associated with radiation therapy in the short term and long term.
So with radiation therapy, we've gotten very good at the short term, and the main ones there are inflammation of the heart. But as Dr. Cole mentioned, we've gotten much more precise in how we aim the beam. Really, when we think about radiation therapy, we think more long term. And there's actually a survivorship clinic that we're both involved in, that we look at individuals who've survived things such as breast cancer and otherwise, and try to assess their risk, because we know, as Dr. Cole had mentioned, that radiation can cause scarring. This becomes particularly important in the heart, where it can affect the vessels of the heart. So individuals may have coronary artery disease or blockages in the arteries of the heart that develop because of the radiation therapy, but it occurs up to 10 years afterwards or 15 years afterwards. So it's really a long-term latent effect that occurs with radiation, and why prevention becomes so important in these individuals.
All right, and as we wrap up the first part of our program tonight, before we get to your questions in just a moment, you brought along some ABCs and a D and an E for cancer survivors that are going to help them. So go right ahead.
So yeah, so as I said, prevention is what we aim for, and we want everyone to have a good, long, healthy life. And the way I think of it and the way I talk to people about it is very simple, the ABCDEs of heart health. And it's simple, and one of it is alcohol. So you can have alcohol in moderation. We typically recommend 2 drinks for a man, which may be a beer or a glass of wine.
That's up to 2 drinks. You're not recommending 2 drinks.
I'm not recommending. And up to 1 drink for a woman. If you don't drink, we don't recommend drinking.
Okay.
But it's important to take it in moderation if you do drink. The other thing is blood pressure, making sure you have your blood pressure checked at least once a year and getting it under control. Same with cholesterol. If you're above the age of 40, you may want to get it checked at least once a year. Making sure that you have a healthy diet, and also if you have diabetes, that it's well controlled. And finally, to get exercise. And exercise doesn't have to be much. I just recommend for people to walk at least 20, 30 minutes a day. The guidelines recommend doing moderate activity up to 30 minutes a day, at least 5 times a week. So if you can do that, great. But you know, just walking, honestly, will give you benefit than sitting on the couch.
And whether you're a cancer survivor, a heart patient, those 5 things are things that are going to keep you healthy regardless of anything we've talked about tonight, right?
Absolutely.
All right. Well, we're going to take a break. We're going to come back with your questions in a moment. Again, our phone number is 504-866-3200. That's 866-3200. Or send us questions by email at hhquestions@wlae.com. We'll take a short break and be back with your questions in just a moment. This is Hello Health on WLAE.
I need help finding a doctor.
PACE.
I needed help with my medication.
PACE.
I needed help getting around.
The Shirley Landry Benson PACE Center is a place that helps seniors remain in their homes, providing the care they need. If you or a family member are over 55 years old, you may be eligible for benefits offered by PACE. For more information, contact us at 504-835-0006. PACE, caring for those who cared for us.
You're watching WLAE, New Orleans Public Television. Find us on Facebook and follow us on Twitter.
We can beat this. The spill in the Gulf, it's a catastrophe.
But we will solve it.
This is not a Gulf Coast issue.
This is a national problem
that requires a national solution.
But what can you do to help?
What do you have to offer? Your voice.
Speak up.
Add your name to the petition
demanding restoration and protection
of America's Gulf Coast.
Sign it.
Share it.
Be the one.
Be the one. RestoreTheGulf.com.
And welcome back to Hello Health on WLAE. Tonight we're talking about heart disease and how certain cancer-related treatment options like chemotherapy and radiation might put you at risk for heart disease with Dr. John Cole and Dr. Eamon Jahangir. And now we go to your questions. Let's start on line 3, all the way in Houma tonight. Floyd is calling us. Floyd, welcome. You're our first caller on Hello Health.
Hi, thanks for taking my call.
You're welcome.
I've had arrhythmia problems just about all my life until medication wore off, and I had my first ablation done about 12 years ago at Ochsner. 5 years ago, I had a stent put in. Last April, I had my second ablation done. This coming Monday, I'm probably going to have my second stent put in. My question is, should I have to have chemotherapy or radiation done in the near future before? Would that cause any more problems than I have now?
Floyd, I appreciate that question. You know, what we're trying to do with the cardio-oncology clinic is prevent future damage in heart disease. And the benefit of the medications that you're on currently is that if you do need chemotherapy or radiation in the future, you're probably already on the medicines we'd put you on. So I wouldn't worry about in the future, if you need it, you know, do we need to put you on the right medicines? I think that if you need a stent on Monday, potentially, that I would go ahead and go forward with it. And then in the future, if you do need more radiation or chemotherapy, then that's something we can have a discussion with. But the good news is that you're probably already on the best medicines for your heart because I'm assuming that your doctors have put you on those.
And the other important thing is that the best way to make sure that you're able to undergo future treatments is to stay healthy now. And so, you know, taking good care of your heart, making sure it's working well, would give us the ability to have all the options that you might need for further therapy. And our focus on making sure that our treatments are done in a fashion that's safe really would allow us to make sure that we individualize treatments for any patient who might have pre-existing heart disease of any type.
Floyd, did our experts handle it for you?
Thank you very much. I'll probably, if y'all look for me, I'll probably see one of y'all Monday.
Look forward to it.
Thank you, Floyd, for your call. We appreciate it. Our phone number is 504-866-3200. Let's go back to the phone lines. Julie calling us from Metairie this evening. Julie, welcome. You're on Hello Health.
Thank you for taking my call. My question may be a tad bit complicated. I have been an Ochsner patient for 30 years. And I come from a family that has a history of heart disease. My mother passed away from a massive coronary. My sister did also, and my 48-year-old niece did only 2 years ago. I've been watching my heart since I'm 39 years old, and I'm 68 now. I've been taking yearly treadmill cardiovascular tests. Once in 2008, it appeared I was having a heart attack. I was rushed to the main hospital, and all of the tests were done, including a scan of my aorta, and found nothing to be a problem. And the following day, I went to my primary care physician, and she looked at the scan, and she said, "You did not have a heart attack, but you have cancer on your kidney." Now, my question is, I had this tiny tumor removed from my kidney, and now I'm cancer-free, needed no radiation, needed no chemotherapy, but I'm still being treated for heart disease with cholesterol medication, blood pressure medication, and yearly treadmill tests. I'd like to know how I deal with this complicated heart problem, and additionally had cancer.
So I think the first thing to say is congratulations, Julie, on being a cancer survivor. You're joining that ever-increasing group of people who are cancer-free after having a cancer diagnosis. And I think that your issue is exactly what we're talking about tonight is is that how do we make sure that people like yourself who are done with their cancer do well with their heart?
And Julie, it truly sounds like you're doing all the right things. It sounds like you're seeing doctors, you're taking care of your cholesterol, you're making sure your blood pressure is well controlled. I take it that you're trying to be active and walking. Those are all important things, and I'm glad that you're doing them, because you're right, now you're a cancer survivor. Luckily, you didn't have to undergo some of the therapies that could damage your heart, and now you're doing all the things to go forward and prevent heart disease, especially with your family history. So congratulations, and keep up the good work.
Julie, thank you so much. We appreciate the call. So is it, when I first heard her telling the story, is it possible that some small tumor could mimic the effects of a heart attack?
Probably totally unrelated. I think in this case, just good luck that a test done for one reason showed something else, and that actually is not that rare. It's a lot of times somebody will show up with a particular symptom, and we find something on the scan that has nothing to do with their symptom, but that is important to their health.
Yeah, and it's 68, and Julie gave her age, so it is okay in this case to tell a woman's age. And with all the heart issues she's had in her family, she's going to take every precaution getting there. Julie, thank you so much for sharing your story and for your question tonight. Line 5, Parveen calling us from Metairie this evening. Parveen, you're on Hello Health with Dr. Jahangir and Dr. Cole.
Thank you so much for the call. Hi, Dr. Cole and Dr. Jahangir. Good to see you on the screen. My question is, 10 years ago, my husband received the treatment for multiple myeloma, and for some reason, his ejection fraction fell down considerably, and since then, the doctors put him on metoprolol, and he has been taking since then. And from that time onwards, he also had problems sleeping at night. And for a few years, he took the sleeping pill, but he started getting some memory loss, so we discontinued. And we recently consulted a sleep doctor, and he says that metoprolol can cause difficulty in sleeping. Now, my question to you is it safe to discontinue metoprolol? And if we discontinue, will the ejection fraction be affected again?
So what I would recommend, Parveen, is that you talk to your physician. And it is true that metoprolol can occasionally cause difficulty sleeping. And in some people, it actually has the opposite effect. I would be hesitant to discontinue the metoprolol without talking to a physician, because there are other alternatives that may not have the same side effects for your husband, such as carvedilol or other medications such as ACE inhibitors. So what I would really recommend, because it's an important question and you want your husband to feel well, is to talk to your doctor and see what other alternatives there may be.
Okay. Parveen, thank you for your question tonight. Let's go to Diane calling us from Algiers this evening on line 6. Diane, you're next on Hello Health.
Yes, good evening. Thank you for taking my call. I've been with Ochsner a long time, and I just want to say I love all the doctors in the Ochsner system. I was treated, I had a lumpectomy for ductile carcinoma in situ, and I had 6.5 weeks of radiation last summer. I've also been on 4 types of blood pressure medicine for about 10 years. I'm on tamoxifen right now also, and I'm also pre-diabetic. I get tested by my primary care, for my blood sugar. Is it a worry with the radiation that I've had and the blood pressure medications I've been on even before the breast cancer? Is it something I should worry about with my heart?
So what I would recommend, Diane, is that, the radiation typically doesn't cause high blood pressure, but it does sound like you've had that for some time. When people get up to having 3 or 4 blood pressure medications, I do recommend being seen by a cardiologist. And the reason is just to make sure that the medications are optimized and that you're on the right doses to keep the blood pressure under control. I wouldn't worry that the blood pressure and the radiation in and of themselves would be an issue, but what you want to do is continue to take good care of yourself, which includes the blood pressure management and also making sure your cholesterol is well controlled, your prediabetes is well controlled, and any other types of risk factors are well controlled so that you can have a long and healthy life.
Dr. Cole, anything to add there?
Sure. I think that, again, since radiation is commonly used in treating patients with breast cancer who've had lumpectomies, it's also important to know which side the treatment's done on, because for right-sided breast cancers, the cardiac exposure is very minimal. And so we really primarily worry about those patients who've had left-sided breast cancers that are treated. And even in those patients, fortunately, the risk is very low. So although it's a possibility, I don't think it's something that I would say that you need to spend a lot of time worrying about. And I would agree with Dr. Jahangir. The most important thing is to make sure that your blood pressure is optimized, because that's clearly a much more important cardiac risk factor than the radiation, I think.
Good clarification. Thank you, Diane, for your call, and thank you, doctors. Line 1, Lisa next on Hello Health. Go ahead, Lisa, with your question. Lisa, are you there? Okay, looks like we may have lost Lisa, so Lisa, we'll invite you to call back if you can. Line 2, Antoinette calling us from Kenner. Antoinette, you're on Hello Health.
Hello, Doctor. I'm thankful that you've taken my call. I'm 80 years old. I am very good health. I've never had heart problems, cholesterol. I've never taken never had to take any kind of medication in my life. I wanted to ask something about melanoma that I accidentally saw on the computer when I was looking up for ridged fingernails, what causes ridges in the fingernail, and they showed a toenail, and I have a toenail that looks exactly like the toenail that I never did bother with, because it's just a crooked brown layered toenail. It doesn't hurt, and but on the computer it said melanoma, and it showed that. Now, in the past 9 months, my weight has been going down, and I'm down to 100 pounds, and I'm 5'6", so I'm way below my normal weight.
What is your normal weight, Antoinette, just to give us some perspective?
My normal weight would be around 130 pounds.
Okay.
So I think the question really that you're asking, Antoinette, is, what's going on? Is there a serious problem that you need to be aware of? And I think the first place to start would be to go see your primary care physician and get a complete physical examination, get some blood work done. And then if there's a question about anything in terms of your skin or nails, then a referral to a dermatologist, an expert in that area, who clearly, if there's any sign or symptom related to melanoma, would be the most qualified person to evaluate that.
Antoinette, thank you so much. And certainly not trying to scare Antoinette anyway, but severe weight loss like that, is that a symptom of cancer in some cases?
It's a symptom, I think, of something that's not right. Sometimes diabetes or some other cause can cause that. So unexplained weight loss is something that should be investigated. Sometimes it turns out to be no medical problem, but it should be investigated.
All right. Antoinette, thank you for your call tonight. Let's go to some emails now, Doctor. In 2000, I was treated with, for the emailer writes, I was treated with chemotherapy for breast cancer. In 2011, I was diagnosed with heart failure at age 65. I had no other risk factors such as high blood pressure, heart attack, diabetes, and was not a smoker that would have contributed to this heart condition. However, my father died of a heart attack at age 41, and my brother died of heart failure at 61. He was a heavy smoker and had a heart attack a few years prior to getting diagnosed with heart failure. In your opinion, doctors, would you attribute my present condition to the chemotherapy treatment, even though it was 10 years ago, or family history? This is from Diana in Covington. Diana, thank you for your question.
Well, Diana, I think you touched on a very good point, which is, and you noticed it yourself, you actually have pointed out two risk factors. One would be the family history, because it does appear that your father passed away at a young age. And also it would be the treatment you received. Now, I'm not sure exactly what chemotherapy treatment you received, so it depends on what you just received if it was potentially a risk factor for having heart failure. What I would say is that before attributing it to heart failure, I would look for, before attributing it to chemotherapy, I would look for other causes of heart failure. So do you have blockages in the arteries of your heart that could be causing it? did you have a virus when you were diagnosed with it? There's lots of things that can cause cardiomyopathy or heart failure, and chemotherapy is just one of the small portions of that. The important thing when you're dealing with heart failure is to stay on the medicines, to see your doctor regularly as they think is fit, and also do things like weigh yourself every day, make sure you have a low-salt diet so that you stay healthy going forward.
And Dr. Cole?
I think the other important aspect of this is that the risk of developing heart failure from treatments may vary from a temporal perspective. That is, there are some types of chemotherapy, as Dr. Jahangir mentioned earlier, where the manifestation of cardiomyopathy or heart failure may occur many years after the treatment, and so it doesn't always have to happen right away. There are other types of treatments where the risk of heart problems goes away fairly promptly after those treatments are discontinued. And so the type of treatment also has may have a different pattern from a time perspective in terms of when the risk might occur. But I don't think we could say for sure that the chemotherapy did not play a role.
We do not have a lot of time left, but we'll give our phone number one more time, 866-3200. That's 866-3200. Another email question, doctors. Is there such thing as a cancer shot? This is the downside to emails. That's all we've got at this point. And this is from Pat. Pat, thank you for your question. And we actually saw this one before the program started because we received the email before the program started. Doctor, you said this may have something to do with bone marrow, right?
So we use injections frequently to stimulate the bone marrow for patients who have had chemotherapy, which normally suppresses the bone marrow. So that's one of the negative effects of chemotherapy. And we use these injections, which are called growth factors, to stimulate the recovery of the bone marrow more quickly. We do not have an injection that we can give that will mitigate or prevent any cardiac side effects. So we don't have a preventative treatment. What we have there is early detection and careful monitoring.
Okay, this is something Dr. Cole talked about earlier, the position of the heart, but let's get to this next email. Since the heart is on the left side, is there any potential damage to the heart in cases of breast cancer where radiation is only on the right breast? This is from Vicky, and again, we touched on this earlier. Dr. Cole?
Right, and so Vicky, the answer is that the risk for cardiac effects from a right-sided breast cancer treatment should be extremely small. And that's really based on the fact that the radiation oncologists these days are able to really avoid the heart by using radiation techniques where they can aim the beam so it doesn't go through the heart at all.
All right, go ahead, Doctor, very quickly.
And I think it makes a good point that we're only talking about radiation to the chest and the neck. If you have radiation to your prostate or something like that, your risk of heart disease is negligible from that radiation. So I don't want everyone to think all radiation causes it.
Very good. Great information tonight. I want to thank Drs. John Cole and Dr. Jahangir for the education and the information they provided tonight and for their continued work in the Ochsner Health System and their investment in this city. To make an appointment with any Ochsner physician, including tonight's guests, or to register for any of our Ochsner Hello Health seminars, you know, they happen almost every week across the city, you can call Ochsner at 504-842-5669. That's 842-5669, and that's a number set up just for viewers of this program. As a reminder, you can rewatch tonight's presentation or any of our Hello Health programs on our website at WLAE.com or on Ochsner's website at ochsner.org. Our thanks again to tonight's guests. Thanks to Humana and Ochsner for making our program possible. And our final thanks, as always, is reserved for you, for your support of this program, Hello Health, and our station, WLAE.
Hello Health on LAE has been presented by the Ochsner Health System. 850 physicians and 90 medical specialties working with a team of more than 13,000 employees provide nationally recognized health care across Southeast Louisiana. Ochsner, health care with peace of mind.
I call it my one less thing to worry about plan. With a Humana Medicare Advantage health plan, I get more clear information about my options with 24-hour access to my Humana, my secure website, and I can get help every step of the way from a Humana Market Point representative.
More of what you want, because you deserve more.